First of all, just in getting started, I would like to say Happy Rare Disease Day. I know it's a few days early, but for us, this is the launch of Rare Disease Day here 2022 in Canada, and certainly it's going to be taking place right across the globe. So we're all in really good company, and I really am so excited by all the people that are joining us in terms of this opportunity, because it's also the launch of what we will see as the rare disease drug strategy. And this is our opportunity also to get a little bit updated on it, but also to invite all of you to come and join us as we move forward in terms of really rolling this out in the way that we want. Should we just put the slides up and I'll go through them quickly? There is a chat line. If anybody wants to put comments in there as we're going along, please do. We are going to, I think, as you will see, we've got a format that hopefully allows an opportunity for people to actually input, questions along the way. So this is Rare Disease. It is the year of the tiger, so I'm very excited and proud of that. Those of you born in the year of tiger know that we tiger people are very, very fierce, really very much goal-oriented. So this is a good year for us to make things happen. Next slide. So this is very important for us. I just wanted to put this up, and we want to do a shout out to Phenotyps, who has been a really great, not just a partner for CORD, but is a unique organization across the globe that is really making tremendous innovation in terms of how to diagnose rare diseases, and really has put Canada on the map right across the world. We're really excited that they're announcing the Upside Foundation of Canada to support CORD, Shield Foundation, and Sick Kids Foundation. And we're happy that they have actually chosen, to set this up in Canada. It is a registered charity. You can see it all. It's empowered over 350 Canadian startups to pledge 1% of their equity to charity. Hugely important. I mean, it doesn't have to be for rare diseases. We're just delighted to actually see the kind of investment that's being made, and then they're converted to a cash donation. We think this is as unique as Phenotyps itself is in terms of what they're pioneering. We know that technology, we know that AI is the future in terms of our being able to do not only diagnosis, but also drive the appropriate kinds of medical care, and certainly the management in terms of treatment for patients. So we're so thrilled to be part of the Phenotyps team. And those of you who have been with us have had the privilege of the founders of Phenotyps being on some of our previous presentations, and we will definitely be able to have an opportunity to hear kind of what they're contributing and where we are in terms of the kinds of initiatives that they've got. So thank you so much, Phenotyps. We're thrilled to have you as a partner, and really thrilled with the unique way in which you're actually raising not only the contributions for this, but also engaging others. Thank you. So here's our agenda. We're going to do it, and I'm going to try to do it quickly. I'm also going to try to do it quickly without just speaking in double time, which I tend to do when I feel there's time pressures here. Very quickly, how we got here. What's our vision over the next 5, 3, and 1 year? So projecting out here, this is 2022. We're right on the cusp of launching the rare disease drug strategy. What do we think this can look like in 2027? And what do we need to do to get there? And then reimagining, as I say, how do we get there? This is the very first webinar that we're going to be starting, to address this as a planning issue. But as you can imagine, it's not going to be the last one. And really, we're hoping to be able to lay a bit of not just a blueprint, but a strategy going forward, in which we would like to have each and every one of you who are on this to actually come and join us. We're going to be setting up some working groups. We're going to be setting up some programs and initiatives. And we really would love to have, people that are taking a real active role in it. Next slide, please. So here's our panel, and I'm just delighted with the breadth of the panel here. Etienne Richet from CHR, Terry Lacaze, who's with us from Meissen, Fred, who has been a huge champion for us all along, speaking on behalf of not just Pfizer, but the industry. Sandra Anderson, of course, as you know, who has been with us consistently in terms of helping to not only shape what it is that we do here, but also providing the support programs for rare diseases. Paul Wilton, who is vice chair of CORD and really has been a long-term, patient advocate. I always joke about Paul, as I knew him when he was still in kind of knee pants, but thrilled that he's now a PhD candidate and is still remaining involved as a volunteer on behalf of not just his own rare disease, but now stepping into a role with CORD. And Michelle Mujumdar, who is the Director of Specialty Pharmaceuticals at Health Canada. We're so delighted that she's able to join us and really provide a bit of the perspective from the government, Health Canada. Next. So this is what we're saying, rare disease drug strategy, reimagining health for rare and non-rare. And this is really important. We're going to be talking about the rare disease drug strategy, but hopefully as we're talking about it, but even more importantly, as we're building it, what we're going to be talking about is a new way in which we can not just do drugs in Canada, not just a new way in which we can actually monitor and manage it, but what is the kind of healthcare infrastructure we need in order to deliver optimal benefit from the therapies, but also making sure that we've got the right patients, that we're going to be able to keep them, affordable, sustainable within our healthcare system. And this is, of course, as we say, not just for rares. And I think as many of you will know, rare diseases, targeted therapies, precision medicine, we're all coming together. So this is an issue that's going to be front and center for many, many much more common diseases as we start to get many more targeted therapies around some of these other disease areas. This is important. We've got to figure out how we're going to do this and do it differently. Next slide. So I just wanted to start and put on the table, and we're not going to go into deep detail. I mean, one of the reasons, obviously, that we're trying to put together a new drug strategy is the old one hasn't worked. And I say that bluntly, and I'm sure that anybody who's here, knows that, whether you're here as a patient, whether a family member, healthcare provider, whether you're here because, you have been trying to help access and source these therapies on behalf of, a drug plan, or certainly whether you're here as a payer or as a industry member, we know it's not working. We're not getting the therapies to people in the way that we should, not in Canada, and quite frankly, not anywhere. And these are some of the cute, amazing challenges that we've had to deal with over and over again. Spinal muscular atrophy. Well, this has been a stepwise process, going from having no therapies to finally getting the first therapy, to be able to get to a gene therapy, to realizing that we could really diagnose people if we had newborn screening, to having no newborn screening, and now getting newborn screening. And a shout out to Saskatchewan, which just put newborn screening for spinal muscular atrophy onto their list. This is really, really valuable. And this is, the kind of things that we're talking about. We also do the shout out to Saskatchewan because they put it on there, without necessarily saying, okay, we're going to go through a long project to see if it actually makes sense to do it. Kudos to you. It does make sense. Saskatchewan was always one of our provinces that actually had the highest number of diseases in their newborn screening, and they're continuing to show that, they want to lead the way here. Retinal diseases, as many of you have been with us know that this is a very important therapy that's come up with gene therapy, but again, still not funded for many of the patients who need it. And now more than a year out, we've got patients who the window of opportunity for them to get treated without losing their sight is closing. And we can't seem to figure out how we're going to get these therapies to these people. And I think this is something that this drug system has got to address if we're going to have a strategy that works. I go back to always the fragile bone diseases, hypophosphatemia, hypophosphemia. The challenge has always been, we're going to give these drugs to people, kids, but not to adults. Cystic fibrosis, good gosh, these are the people that know each drug that comes out. It's been really a matter of an out and out, advocacy campaign in order to get therapies. It's people that are putting themselves and their lives, right on the line to raise attention. This is not the way in which we can do it. And yet we seem to be doing this over and over again. Kudos to everybody that by the time we got to the last drug that we've got right now, it seemed like once we got through all the other battles, that many of the provinces picked it up fairly rapidly for Orkambi. But, this is something that we need to absolutely be institutionalized rather than be the exception. We're really excited about the first therapy that's coming on for fibrodysplasia ossificans progressiva. It's a drug made in Canada, invented in Canada. We were with clementia all the way until the drug was actually going through clinical trials, was picked up by Ipsen, and now it's coming back. Canada became the first country in the world to actually approve this therapy. US is still, tinkering around with it. We rarely get to be first. Our concerns are we going to now wait another 2.5 years for it to go through the normal process to get there? Porphyria, this is a really amazing therapy for a very, very small patient population. It's only for a portion of that patient population, but guess what? It's stuck. It's not getting through to the review process. It was also got a recommendation from CADIS that was actually sort of a backslap because it actually put in there a huge, huge concern around the cost effectiveness using some, old benchmarks that we thought we had gotten away from. And then we still have the notion of Prader-Willi syndrome, where there's a generic therapy that's out there, but still not getting to people. So I'm spending much more time on this than I wanted to. Next. Just these are some of the pictures. I don't want to go into them. Your slides are going to be made available. You'll have them as a reference. More importantly, we're going to come and pick up these cases in our next set of workshops so that we really are going to try to build this rare disease drug strategy based on real case examples of where the system has not been working, where it's really had the huge challenges for people getting access, and what do we need to do in order to close those gaps? Because for us, at the end of the day, the system has got to work for each and every person. So identify what is it in the system that's not getting drugs appropriately to people. Let's build a system where we do not perpetuate these. So this is Michael, many of you will have known, has been with us for a long time, started off way back in 2013, trying to get access to a therapy to get a kidney transplant. Shortened line here is that he couldn't get a kidney transplant because he couldn't get access to a drug that would keep his body from having the kidney fail once he got the transplant, but he couldn't get the drug because it wasn't funded for people who needed a kidney transplant. So poor man was caught in this loop for like more than 6 or 7 years while everybody dickered around trying to decide, Finally, through huge strenuous efforts on his part, he actually not only got the drug approved, he actually has gotten a kidney transplant. And he's now doing well, but he's really worried that the drug is going to continue to be funded. Not a great scenario, but kudos to Michael. Next slide. These you've seen before, we're not going to belabor them. This is the gene therapy drugs that we've talked about before. Next slide. You'll get a chance to have these. This just is, I think everybody knows here, we have this hugely long process in terms of patients getting access to therapies, where along each step of the way, there seems to be a barrier in terms of people to be able to get access. Yeah, Marina, I echo what you say. Hooray for Michael. And it really was his work. And what we want to be able to do is to, for rare diseases especially, we've got to, bypass this process, because this is what's happening in terms of the drugs getting delayed and not getting to people in a timely fashion. Next slide. This is what you've seen. We know that, on the average, 18.9 months from Health Canada to a PCPA agreement. If you've got a rare disease, if you've got one of these drugs that, Canada has deemed to be, extremely, out of the guidelines of what they consider to be cost effectiveness, it can take many more, and it can take up to 7 years in some cases. This is not acceptable for drugs that are absolutely first in therapy for treating severe progressive diseases. Next slide. This just puts back into context the fact that, despite all of this hullabaloo and this, wailing and moaning about how expensive rare disease drugs are, at the end of the day, the budget impact of these are really, really small. We're not talking about drugs, and nobody can ever suggest that, it's going to swamp the budget. Yes, if you have a small drug plan. Yes, if you only have, a limited budget, but that's why we need this drug strategy. What are the ways in which we can coalesce and pool, the resources so everybody can get timely access without bankrupting either the individual or the individual drug plan? Next. So this is some of the things we've already seen. Canada is not a leader in terms of funding drugs for rare diseases, as you can see, relative to other countries, and certainly relative to the number of drugs that are available. Next slide. This I won't belabor. It was just my little bit of a joke in terms of what the future is and how we can have a drug strategy. I mean, what is our future world? And people sort of say, well, how can we be focusing on this when in the midst of COVID? And I think what we're saying is that, well, what are the possible COVID worlds? Is it going to be kind of back to the future? 2019, we're going to be able to say pandemic's over. We'll pick up where we are in 2019. Of course, that's where the rare disease drug strategy got born, because it was not working well then. So, we need to do the investment in rare diseases and in R&D. Is it a future world? This is one that we're hoping we've kind of walked away from, where 2020 looks like 2021, looks like 2022, and looks like 2023. And who knows how many of these are going to resurge as we get more variants or other, kind of pandemic diseases. Hopefully not. But even in that, we do now recognize we've got to take care of the chronic diseases and certainly rare diseases. And this strategy will be even more important. And what we're hoping will be the future world, and that is Dr. Strangelove, where we can say, okay, this has now become an endemic. We don't have to worry about it. We just learn how to live with it. And again, our rare disease drug strategy then becomes that parallel path in terms of these targeted specialty drugs. Next slide. Okay. I won't belabor any of this. I mean, I realize I have way too many slides here. I just want to put into context. We've oftentimes thought, what are the two biggest drivers in terms of the health ecosystem? One is innovative technologies, no doubt about it, not just medicines, but all kinds of technologies. And the second, though, concern is, in fact, health financing. Would the technologies become greater impacts in terms of healthcare spending? No doubt about it. But if we rethink healthcare spending as healthcare investment, as investment in the industry of healthcare, I think it becomes a whole different proposition. It's sort of like saying, look at this, we have greater cars, we have better, sources of energy, but guess what? They're going to cost a lot. It's not the cost, it's the investment in them, because the investment in them pays off tremendously. Next slide. At least that's our philosophy. The other concern we do have is the fact that there are more and more rare diseases. It's Rare Disease Day. Guess what? There's about 200 new identified rare diseases every single year. That's interesting. We can actually identify the genetic causes of over 4,000 of these. So, we can diagnose these diseases. We don't often know what to do with them and what the genetic mutation causes, but we can identify them, and that's a good starting point. What we also know, though, is that even though, many of these are pediatric, we've in a quarter not paying attention to some of the others that are caused by environmental factors. And we had a great webinar on Monday with some folks that really talked about other sources of rare diseases. When we talk about how many rare diseases there are, and oh my God, are we going to get overwhelmed by the fact that so many of these new rare diseases are going to have therapies? It's going to be a straight line in terms of cost, recognizing almost 85%, of these rare diseases have a prevalence of fewer than 1 in 1 million. So a whole different strategy is going to be taken into place in terms of how do we get therapies for them and how we're going to finance these. But these are not going to overwhelm our budget. So I think that's really important. About 80% of people with rare diseases are actually fitting into the little more than 4% that we've already identified. So this is not a straight line in terms of more and more diseases. So I do think that, we've got an opportunity here with the rare disease drug strategy. Let's think differently. Let's do differently. But we also do want to be able to find therapies for and to be able to support those that have fewer than 1 in a million. Next. This is just the global agenda. I only put it up there because we are part of the global environment. And of course, two major events that have taken place. One is the recognition of rare diseases as a specific disadvantaged population under universal health coverage with the WHO and the UN. And also, as importantly, the United Nations passed the Declaration on Rare Diseases, recognizing the needs of persons living with rare diseases in terms of social, economic, occupational, educational, gender inequities, and that rare diseases is a holistic, set of needs, not just in terms of medicines. And Monday, some of you will know, is that we will be celebrating Rare Disease Day at the World Expo in Dubai, where we'll be celebrating the declaration of the UN Declaration. Next slide. This is kind of what it addresses. I won't belabor it. You can look at it later. I think we should be almost done here. Just to get back into the 5 key pillars of the rare disease strategy, and I will probably stop here, not go into each one of the pillars, because we will do that in our May 23rd and 24th workshop. What we have said consistently around the rare disease drug strategy is that it really isn't about drugs. And that even if we were to, kind of get to the point where we could actually think about how do we fund these therapies, there's no way that we want to put these funds into just offsetting the cost of therapies. We're not going to be able to hand them out. We need to have a proper health infrastructure around them. We've got to be able to have what we call the 5 key pillars. We produced this, Rare Disease Strategy 2015. They still hold up as the fundamentals for what we need to put in place if we're going to be able to bring drugs in, make them accessible to people, and make sure also that they're going to be used effectively, cost effectively. So first and foremost is, why don't you flip to the next slide, and we'll kind of just do them one at a time. Oh, this is just looks at what the pillars are. I apologize. Back up then. I'll just kind of finish that off. Sorry. So, diagnosis, early detection, centers of excellence so that we can get them specialty care, huge amounts of community support, recognizing also the community-driven needs in terms of rare disease patients. Obviously, the access, most important area in which we've been neglected is, in fact, supporting and promoting innovative research. The next slide, Bill, I'll just do this quickly. What we've identified in this vision is to say we've got to have 3 major building blocks. One is we've got to optimize the infrastructure. You've already heard me talk about that. We're going to be spending a whole lot of time in the next few months really drilling down to define what that infrastructure is, who needs to be involved in it, developing and defining the centers of excellence. There's a huge opportunity coming up with the collaborative global networks for rare diseases, where we hope Canada will actually put itself forth to try to get one of the projects, the pilot projects for setting up network centers of excellence. It's a huge opportunity to be a leader in that global community. Second thing is we have to have a drug supply. I mean, one of the reasons we've been fighting so hard in terms of support for innovative research is that we recognize Canada has to be part of the development of drugs. We've got tremendous expertise in our research areas. We've got tremendous expertise even in our manufacturing capabilities. How do we make sure Canada is contributing in terms of innovative research, but also research around other areas for rare diseases, care, support, monitoring, best practices there. And this is why we're so excited to have Maestrin really as a strong supporter. How do we make sure that we've got the clinical trials networks that we can actually get drugs in and make them available to people in that trial phase? This is all part of, developing our capacity to have drugs. And of course, as many of you know, we fought so hard on the Patent Medicine Prices Review Board in terms of what we saw as really crippling, regulations that would keep drugs from coming into Canada in a timely fashion. And we were very pleased with the fact that much of that seems to at least been put into a really slow halt, if not an actual death spiral. So maybe we can make sure that, we're able to continue to ensure drugs are coming in. And then the last pillar here is as important, and that is how do we make sure that patients are partners? And how do we actually develop patients to be, really effective expert partners, and that we're able to also have genuine roles for patients in each and every part of the drug approval access process. Next. This just lays out a 5-year strategy. We'll come back to it, and we hope that you will be intimately involved with it, and we'll be able to know this and recite it on your own. Next slide. Okay, these are the components. This is what we're going to focus on the March 23rd, 24th, and also in our June conference, which we hope will be in person in Ottawa. So in the week of, I think, second week in June, whatever that is, we're hoping that we will be in Ottawa in person to be able to host a real work session as well, much as a celebration session. So just flip through, Bill. So it's the same things I've already talked about. All right, this is in the steps. Many of you have been along the way. We won't belabor it. I think we're almost done. So we can go on. This is where we need to go next. This is, again, what we're going to drill down in our next sessions. Next slide. This is really important. I'm so excited about this. We're just getting this set up. This is our new website. This is our new advocacy website. This is a website also in which you can hopefully take an active role, because we do know and we believe that we've got for sure the commitment to setting up a rare disease drug strategy, but we need to get a whole lot more engaged. And so we've created a website where you can take an active role and actually be able to express, your opinions around it, but also be able to express to your members of parliament, to the ministers of health, to your provincial leads that the rare disease drug strategy has to come into place, and that we need to have really broad-based support around it. So this will be up. It's not quite up yet, but once it's up, we hope you'll go on to it, share your own experiences, use the Twitter, use the Facebook, sign the petition that we have. We need to make sure. I'm really not at the place of holding my breath thinking this might not happen. I think we've gotten over that hump, and really we are looking at the fact that this will take place, but it needs to take place right. And I'm going to say this again. This is our one chance to get the rare disease drug strategy right. What we do not want to happen is that we all say, okay, we got it, there's a commitment, it's going to happen, and then we allow everybody else to take it over. No disrespect to bureaucrats, but this cannot be a bureaucratic exercise. No disrespect to the experts and to the others. This cannot be something that's expert driven. It's got to be something that's driven by all of us, who are living in this space and have made so much commitment to actually seeing it through and recognize on the ground what all the issues are and what all the possibilities are. So we want to make sure this remains a people-owned strategy. And this is what we're going to be doing. So, if you're enjoying the webinars that we're doing, I hope you'll roll up your sleeves and join us as we do the real work strategies. And now I'm going to stop and I'm going to turn it over to the real work group that we've got here, and that's our panel. And to Bill, who's going to moderate us through it.
Excellent. Thanks so much, Durhan. And just a quick note on the website. Canada #4 rare has become a real hashtag. It was a very awkward chant that some of us were using in Vancouver, I think in 2015, if I'm not mistaken, Canada for rare, but it has become a bit of a rallying phrase anyway around this issue. So canadaforrare.ca is where that website's going to be. So keep an eye on CORD's communications for that opportunity for you to engage across the country. We've got an incredible panel today, and Durhan, thanks for setting it up so well. I see we've got Etienne, Thierry, Fred, Sandra, Paul, and Michelle Majumdar from Health Canada. And let's just get right at it if you don't mind, Durhan. And maybe I would throw the floor first to Michelle to say, what's happening at Health Canada in terms of the rare disease drug strategy that you think that everyone across the country can get behind, because the What We Heard report, which we've all read, actually says a lot of what people said, which was amazing. So why don't you give us the quick lowdown on what's happening in Health Canada and what's next for the rare disease drug strategy that's coming out of your keyboard.
Sure. Thanks very much, Bill. And just thanks for the invitation. Thanks to CORD for the invitation, and in particular, it's quite important as we approach Rare Disease Day. So I very much appreciate that. Well, I think I could go on for a half an hour, but what's been going on and what next, but I'll try to make it quick. In terms of, I'll just say, maybe start off by saying that, I've been following the space for so many years, my previous role, and it was really kind of the challenge that certainly prompted me to take this role with Health Canada, knowing that there was an opportunity to sort of do differently and do better. And I think that certainly motivates me. And I think I can speak on behalf of my team as well, that it surely motivates them. And so it's interesting, the setup with Durhan in terms of what she has presented as CORD's rare disease strategy, and what my team is trying to create in partnership with PTs, with Indigenous partners, and certainly with stakeholders, which is the national strategy for drugs for rare diseases. And I do see some good alignment, which is very promising. Of course, the scopes of the strategies are different, and that's something to be mindful of, with CORD strategy being broader rare disease, but of course including drugs, and the national strategy being focused on drugs to treat rare diseases. But for example, one of the pillars of the CORD strategy, which I know you're going to talk about more next month, is about providing sustainable access to promising therapies, which very much aligns with the thinking in the national strategy. And I guess that's because, we know that in addition to improving drug coverage, we're cognizant of some of the work that Durhan mentioned about needs to happen sort of around that, and the infrastructure that's needed to make some of that happen. So just to sort of start off just by saying, in terms of the scopes of the strategies, But maybe just in terms of where we're at for the strategy, we have a bit of a draft plan for the strategy, which some of you would have seen when we had some targeted stakeholder discussions over the summer, just to drill down a little bit more and get some insights. It's changed since then and evolved, and we're trying to build it out for use in our next phase of engagement. But broadly, there are 4 pillars, so similar in terms of the pillar approach. But promoting national consistency. We know that there is discrepancies across the country. We know that there needs to be improved collection and use of evidence. And certainly there are infrastructure needs that and changes to processes that are needed. And there's some sort of risk sharing funding arrangement that would also be needed, and thinking of innovative coverage models as well. And in terms of innovation, really building on what else is happening. I'm sure we'll hear more from Etienne in terms of CIHR and research, but also aspects of kind of taking a whole of government approach. So in terms of next steps, I alluded to the next phase of engagement, and we had planned to kind of start that in the fall, but it's sort of been pushed out a bit. But so has, we're still working behind the scenes, and that feedback is going to be incorporated, quite frankly, because we need it. We still have some gaps in knowledge. The first phase, as you said, Bill, it was sort of expected what we'd hear, but I think it was great to have it all in one place. It was more blue sky thinking about the possibilities, and now it's really kind of drilling down in this phase 2. So we're looking forward to sort of getting back out to stakeholders, probably in a bit more targeted way. We'll have to do that, but kind of thinking of the breadth of stakeholder groups that we want to reach out to, and hopefully starting those before the end of March. We're thinking of more roundtable approaches with various stakeholder groups. And I think that way it's a good opportunity for stakeholders to also get to see the different perspectives, even within a stakeholder group. We have the privilege of being able to see that, but I think it's important for everyone to see that as well. So maybe I'll stop there, but happy to follow up more.
Fantastic, Michelle. And maybe I'd actually throw it out to Etienne, Thierry, and Fred, because Durhan, you mentioned research centers of excellence and the need for access to early treatment through research, and so much is actually happening in Canada. Fred, you're trying to bring in some of the private sector knowledge from the world. Thierry and Etienne, you spent a lot of time looking outside of our borders as well. Are you hearing from Durhan and Michelle that things are coming together? And what's happening at like CIHR and MyCERN and within the private sector? Do you see these threads coming together that weren't there perhaps in the past, even before we have this strategy? I don't know, maybe we'll start with you, Fred, if you don't mind.
Sure, I can take a stab. Actually, I'd like to follow on what Michelle had indicated, like inspiring, because there's 2 things that to me resonated for the rare disease community. If we can have the framework tackle them, the collection of evidence piece is going to be so critical around how we engage KOLs and the centers of excellence across Canada. And then if you bring in the pharmaceutical rate time to access for medication piece, that will be, I think, important to be able to demonstrate value on both sides. Value for, well, on 3 sides. Value definitely for the patient, because that's where we want to get it. Value for the manufacturer, and then of course value for, for the payer. And if we go back, why is that important? If you go back to what Durhan presented around the pathway to getting medications in the hands of patients, we're looking at about 2, that just looks at time medication. What happens when you bring in diagnosis? What happens when you bring in suspect and detection of diseases? So if you kind of put that in and you wind to look at bringing a new therapy that treats a new rare disease, you're looking at minimally 3 years for any patient can benefit from a new medication. So if we could reimagine, if we're looking at those elements of how could we throw out the current system of this linear approach to saying, how could we have a time zero, meaning when Health Canada actually approves the medication or therapy, can it be readily accessible to patients at that point? So I think that's the journey I would like to get on. I mean, that means it means physicians, it means Health Canada, it means CADA payers, the industry. We need to work together, but I think that's a very patient-centric approach that we should all be looking. And I think everyone will be happy with that, because at the end of the day, the patient will benefit. Anyway, I'll just stop there because it's very inspiring what Michelle had talked about. I think it links very nicely to what we heard, in the earlier presentation from Durhan.
Thanks so much, Fred. And that's, if you think about NOC, is when Health Canada approves a medicine. Even before that happens, there's so much research that's underway, and patients are even getting access through clinical trials and whatnot. And I heard what you said about real world evidence once it's on the market. I don't know, Thierry and Etienne, in terms of the research, how is CIHR and MyCERN, preparing for some of the advances and maybe some of the more the faster timelines that Fred and Durhan alluded to? What's happening at CIHR and MyCERN these days?
So maybe I can start first.
Yeah.
I will let Thierry talk more about the clinical trial aspects, because clearly I think MyCERN, that's an incredible asset in Canada that we do have, and that will be critical, as you mentioned, to bring earlier access to Canadian patients to therapies. But now, in terms of the equity and just in terms of knowing exactly how to allocate resources, I think that one of the big gaps right now that needs to be addressed by research is actually to ensure that every patient can be counted, because if they're not counted, like usually say, they doesn't count. So to make sure that there is a system in place that allows us to really do the epidemiological studies and to know in the hospital what really is the burden of rare diseases. So clearly that's one aspect that will be key into advocating or bringing to bring new therapies and required resources to those patients. Also, in terms of the diagnosis, as Durhan mentioned, really having studies demonstrating when's the best point in time in the diagnostic pathway to actually bring in the whole exome sequencing, for example, or things like that. But also what it represents for the patients, not to do so as early as possible in terms of socioeconomic burden and what it really represents for the life of these patients. So that will bring me maybe to the last point that I will start with here, it's the patient. That's an important component of what Durhan presented, but clearly that's something that is at the core of all the research that we are doing at CIHR that we want to support, starting with the patient and moving up in the system to see really where is the first point where research is needed to actually address patients' needs. And in that regard, I think that in Canada, we are really more advanced than many other these European countries in terms of engaging with the patients and having them at the core of the research that we're doing. We are also working with many partners in that area, like Muscular Dystrophy Canada, and I see Homira, who's here. We're also working with Ataxia Canada and many partners like that over the years. And also at CIHR, we do have the strategy for patient-oriented research, which is morphing into patient-oriented research more generally. And at the Institute of Genetics, more specifically, we have Gillian Banfield, who's also here in the room, that is starting in a few weeks at CIHR as a team lead patient engagement. So we are reaching out as much as possible, and really having that patient included into our research efforts is really key, I think, to the success that we can have, like we've seen over the years with the initiatives like Care for Rare and other across the country.
That's amazing. And maybe just a link back to Michelle and what you were saying about the draft strategy. The vision that we've seen anyway is improved access for patients who need medicines for rare disorders. I mean, that's really core at Health Canada's draft plan. I hope that hasn't changed. I just wanted to jump off of, okay, no, it's still there. Good. It sounds like CIHR is putting the patient right at the center too. Thierry, let's talk about clinical trials and research and what's happening at MyCERN and how that is playing a role in moving this forward too.
Yeah, thank you, Bill, and thank you, Duran, for the invitation. So for those that may not know, MICERN means Maternal Infant Child Youth Research Network. It's an agnostic network, so we don't have a specific interest in a particular condition or populations, but we are here to serve our 21 maternal and child health research organizations across the country, and to enable them to conduct research in the most efficient way. Our modus operandi is really based on the recommendations of the Council of Canadian Academy that was released in 2014, the report called Improving Medicine for Children in Canada. And following the recommendations of this report, we have been working very closely with our founders and members to develop an infrastructure to support clinical trials to evaluate drugs in children in the more efficient way. And we have been able to build, pieces of infrastructure for, many years. And we are extremely happy to see that infrastructure is now becoming, an issue and a priority with this initiative. So Etienne is right. I mean, the engagements of patients in the design, the conduct, and the execution of clinical trial is something that CIHR has been pushing very, very, very strongly, and we are embracing, this piece around, the success in regards to conducting a clinical trials. Most of clinical trials don't actually finish, partially because the engagements of patients is not well thought and well developed all across, the studies. So this is why an organization as CORD is so critical in the developments of this initiative and strategy. So what we are hoping, working, of course, with all our stakeholders across the country, we have 25 networks focusing on rare disease affiliated with MICERN. We are hoping that the fractions of these fundings will go to support an infrastructure to efficiently conduct clinical trial across the country, offering access to any trials to all patients with rare disease wherever they live, and making sure that the equity and the diversity is taken in account to facilitate access of those families to clinical trial. We are hoping to develop a structure that will provide Health Canada and the stakeholder with the appropriate data, using data extracted from electronic health records, so really the real world data, and also facilitating the developments of registry. So we are extremely excited to be part of that. We have been involved in conversations now for 6 months at different occasions, and we are actually prepared. Our community is ready to roll the sleeves and to be part of this fantastic initiative that our government is putting on the table today. Yeah.
Thanks so much, Thierry. Sandra, I know you've been watching and listening attentively and really guiding a lot of the efforts around pulling the whole package of the rare disease drug strategy together. So if we succeed with what Thierry is hoping to do in terms of the research and giving access at, through clinical trials and networks of excellence across the country, what happens when even pre-NOC, pre-Health Canada approval, to make sure it gets pulled through the system? And then I want to turn to Paul, who, as a sort of a governance expert as well, and involved in the rare disease community, like, where do you see that system changing in a way that will actually make it work so that it's not just a bunch of stairs and steps, but things work better? And there have been some hints that we've talked about that Durhan has mentioned, but maybe you can start first, Sandra, on what to do after there is a medicine.
Sure. So thanks again, Durhan and Bill, for having me today. Super honored to be here. I think Durhan set it up very nicely. The current framework that is in place to review rare disease drugs is really following a very linear process where there's steps after another and there's different groups reviewing the product. And really what I think the vision is, and what we think we need to strive towards, is a single framework in Canada to review rare disease therapies have a national panel with a transparent review process from the beginning. So when the design of the trial is happening to the time that the drug is, in the real world setting, that you're collecting evidence to prove that the drug is working. And I think that has to start before NOC. So before, like right when it's going into Health Canada and it's being reviewed, there's ways you can have real world evidence collected and it fits into the, the market access or the CADITH review process. So I think that it needs to be looked at differently than what it is now, where it's Health Canada, then CADITH, and then the provinces. Is there a way to consolidate that? And we've seen it in different European countries where the models have been set up. Drugs are approved and then real world on a conditional basis as real world evidence is collected. Patients get access and then to see if the drug is working in a real world setting. And I think that's the way to think about it with rare, given that rare is different. Rare is not a typical product with massive amounts of volumes of patients across the country. So I think if we can define a different mechanism for rare, that's where I think the strategy needs to go. I also agree with Durhan. It's not just about the drug. It's about also making sure that there's access in the community, that there's a community delivery, mechanism, and that the centers of excellence are connected, right? And we've talked about data. I think all of us agree data is extremely critical. The challenge is, how do you consolidate and connect the data? And have a platform or leverage data sources like registries, talking about that, and clinical research. Is there a way to connect it and centralize it so that when you're looking at the patient journey and evaluating if the product works in the real setting, that you have access to data? And not just data locally in Canada, but internationally. I think that no matter what we do, if we're going to have a rare disease strategy in Canada, we do need to involve international access and collaboration and other data sets to be able to evaluate the product in a real world setting. So I think if we think about it a bit differently than the current state, I think that's where we have to go and really aspire to the objective that Durhan has laid out, and recognize that patient access is critical, starting from the beginning and really looking at different ways we can innovate and collect evidence throughout the patient journey.
Fantastic. Thank you, Sandra. Some great ideas. Paul, fix the system for us, will you? Where do we start?
No small task. I think from the patient perspective, we have to think about how do we assure that there's opportunities for patient input throughout the process, either from individual patients or particularly from patient organizations. I mean, these are no longer mom and pop shop operations, kitchen table organizations that are organizing picnics. And in some cases they are, but they're really data-driven organizations, and they realize that's the way of the world. That's how decision makers are making decisions. And they have a lot to contribute to that as well, either through organizations that have developed their own rigorous processes for measuring patient-reported outcomes, or partner with their healthcare providers to track the usage and utilization and outcomes of products. Patient organizations do really have valuable contributions to make. You alluded to the governance piece too, which is, Durhan said what we have in place now doesn't work. I think we want to make sure that 10, 15 years from now, we're not looking back saying the same thing. So in that way, as we implement this, I think we need to be thinking about how we have transparent decision-making processes, how patients are consulted regularly, how there's access to information, but also that we have some objectives related to patient outcomes that we're reporting on. That's the only way that we can have accountability. And that's best how patients can contribute if they know what's going on. I know certainly in the hemophilia realm, where we're very lucky compared to other disease groups, when we have had that transparency, when we have had that access to information and that opportunity to contribute in a meaningful way that's not just kind of lip service, that we've helped decision makers make better decisions. We've been able to question assumptions. Sometimes we know more about adherence or about uptakes based on different variants of our own disease. That helps the decision makers make more cost-effective decisions, but also decisions that make sure that they're helping the people in our community who are most in need.
Thanks, Paul. I think I've said this in previous webinars, and I'm sure it's not my analogy, but there's a joke about Canada being a nation of engineers with no architect. And we can see even over the past couple of months with all the stuff that's happened in blockades and occupation here where I am in Ottawa, you know, the pointing the finger to, no, you take the lead, no, you take the lead. So this is a good way to go back to you, Durhan, to say, you know, the rare disease drug strategy of 2015 was sort of the patients getting out there, taking the lead, and then all of the system falling in with different aspects where they need to show leadership. And before the call, we talked about cancer and the Canadian Partnership Against Cancer and how that all started. Any thoughts there in terms of where the rare disease strategy could go, building on some other those other lessons and you know that have already been brought together? Any thoughts from that?
You're asking me?
Oh yeah, I'm asking you.
Yeah, I mean, I don't want to be politically incorrect, and we don't want to cast any dispersions on on CPAC, right? But quite frankly, we do not want another CPAC. We do not want to build something and then everybody gets around it and you dump a bunch of monies into it and it becomes another kind of a bureaucratic exercise. I think it's really important, as Paul says, we've got the patients built in throughout, but we also have the healthcare professionals, and we also have, all of the other sectors. I was in a great conversation this morning on a global level talking about public-private partnerships, and we could take a big, leaf out of what's happening over in Europe much better, where there is a much more synergistic relationship between, the private sector and the public, and including the public payers. So I think all of that is really important. And that means that we have to continue to be involved. And I'm really thrilled with, what Michelle has been saying in the consultations, but we also know is that, we have to remain involved in terms of putting out these solutions. So it really has to be continued to be owned as a bottom-up exercise, and something that I think, as Paul had said very clearly, with the blood, agencies as well. We've also got to be able to keep one foot out of the system to be able to call them when it's not working, or, when they're proposing something, to be able to challenge back. So, we serve that really important, gatekeeper role.
Thanks, Durhan. And just a quick shout out for another event that's happening on Monday, Rare Disease Day in the morning, just before question period in Ontario. There's an all-party roundtable that CORD is co-hosting with Life Sciences Ontario. So there'll be a post and an opportunity there for people to contribute. And it actually builds on a question that I see in the panel, and the need for the provinces to really be involved in building out their own strategies and approaches to rare. And I don't know if Michelle, you can comment on a little bit or elaborate a little bit more about how the provinces are engaging with you or preparing. Are there concerns with respect to rare disease strategy and funding that we see in the panel, or do they see this as an opportunity and want to get behind it and get involved?
Thanks for the question, and I actually appreciated how it was framed in terms of asks and concerns, and I'll just say that we have the opportunity to work with a great group of people. I mean, from my previous life, I worked with a number of the provincial and territorial payers, and I will say they're smart and thoughtful people, and we have been able to convene an FPT table of ADM level folks who are able to consult with, and they are key partners. They are partners in this strategy. This is not a federal strategy. This is a pan-Canadian strategy, and I think that that's very important in terms of making this work. In terms of some of the thoughts that they have and concerns, I don't want to speak on behalf of PTs and a payer perspective, but they certainly, I mean, could be differences in the way that we sort of talk about the overall challenge to affordability, but we can disagree maybe on magnitude and debate that. But, I don't think that's the point. I mean, what they're faced with, they say that they are facing challenges broadly around affordability. They have, questions about, evidence generation. So, they have a lot of the same questions that, and points that they've raised are things that I hear today, and things that, I've heard through the stakeholder consultation. So, personally, I really do believe that, reflecting on some of the international comments, I worked internationally in HTA, and, I know what they're doing in Europe and elsewhere. I really do believe that, we have a lot of the tools in Canada already, and it is about optimizing them. It is about connecting up the system, but it isn't just about change for governments. I think this is going to, be a change for everyone involved in those processes, from, R&D to reimbursement decisions. And so, including the industry, for example, including patient groups. So I think this is, to some degree, some change management that has to happen, but I do, perhaps optimistically, some call me an idealist, but I do believe we have a lot of the tools already available. We just have to use them better and probably differently.
That's fantastic. Thanks, Michelle. I don't know if, Durhan, we have just 4 minutes left. If we're going to end this at 1, where do you want to go next in terms of who do you want to hear from? I mean, Michelle's actually put down the challenge to everybody that is change management for every stakeholder. Maybe for speaking for Cord, are you ready to be that agent of change to get everyone to get behind what Michelle just said?
I think we need to be, right? I mean, and I'm really, happy and proud of what, Paul has been saying about, the engagement of the patient organizations. And maybe we'll put on the table something you and I chatted a little bit about, Bill, and maybe at risk in terms of thinking too much out loud. And that is, what is the role of the patient community here? And Michelle, I know that you can't give us a definitive answer, but, as all of you will know, Cord is a charity. We're a volunteer organization. I mean, groups like Phenotypes are amazing in terms of coming forth and putting us in there. And we've got huge support from the industry in terms of what we're able to do. But we do want to be a legitimate partner. And part of what we need to do, as Paul says, is that we've got to be, yes, definitely continue to hear from the individual patients and the families. And all the stories you see are the ones that really let us know where are the gaps. And all the voices that you hear out there are the ones that really call for, we need to have this change happens. And that's who, the politicians should be listening to as well. But beyond that, we've got to have, skilled, trained, patients at the table who are actually also, able to help shape not only the strategy, but how it's implemented. So I guess I'm really interested in, Michelle, is there a vision for what that patient role is going to be? We've been outside the tent, we've been doing, I sometimes feel like, we're throwing, hand grenades over the wall, trying to get somebody's attention. And then finally somebody opens the door and they open it up with this tiny little crack and a few of us get to trickle in there. And then, we get ushered back out, kind of when the grownups want to sit at the table and have a real discussion. Are we going to have that kind of genuine partnership? I've seen what happens in Europe in your orders. We've got seats at the table at CHEMP. We've got seats at the table in terms of IMI. So is that part of the vision? And what do we need to do to make it part of the vision?
Happy, Bill, your moderator, but happy to take that. Durhan, you would know from, my days at CADITH, I oversaw patient engagement, and, I oversaw patient engagement with the European level HTA and at UNETA. And I've read countless submissions from patients and patient groups. And I truly believe, echoing some of what Paul said, they have insights from living with a condition and caring for people with conditions that's important to all steps along the process. Though I was focused on HTA previous career, it's from that whole continuum, from R&D, regulatory review, HTA, pricing, reimbursement, and there are mechanisms for some level of involvement in all of these processes. Some of them I would say we could learn from, what are some best practices internationally or from outside of health, kind of thinking of stakeholder engagement too, and what could be brought in. For the national strategy, we certainly want to aim for meaningful engagement. We want to avoid a tick box exercise. I've talked a lot in my previous role about, illuminating a black box, and I think that that's really important to support meaningful patient involvement really in the process.
That's terrific. Final words to anybody. Thank you so much, Michelle. Like, turn the light on in the black box. consolidate some of the different steps. Sandra, that you said you want to, and Fred, you said it as well. It's like, let's get down to that bottom platform faster. Durhan, final word to you, because you got your finger up in the air.
I put my finger up to say, if there's come join us. You'll hear a lot more from us. I would like, if she's still on the line, I haven't looked at the list. If Maureen Smith is still on the line, I'd love to give her the final word as to where you think we are now relative to, when we first entered this process, because you have been such a stalwart soldier in this entire process. If Maureen is here, I'd love to have her kind of give the final word.
Oh, Durhan, what a privilege. I just tweeted out at the beginning of the meeting that there were over 200 people attending, and for people to hop on, because this is the not miss event. So yeah, I've been involved for a long time. We've always had a strong community. We're all survivors. You don't get through a rare disease without being resilient, but we're different now. We've done a lot of training. We've got people who are, really, understand the process, understand all of the issues, and are ready to sit at the table as equal partners. And it's not one or two people, it's many people in our community now. We've gone beyond, a core group of people to really expanding it. I think my biggest message is that support and training takes money. And if we're going to be equal partners and we're going to participate in this process, we need a commitment from the government to put some money aside. And there's no one better equipped to offer that training than CORD, because they've been doing it for free for all these years. And knowledge is power. And if we really want to participate in the process and we really want our voices to be heard, the people who are at this meeting are all empowered to do that. And we're just waiting for that word. I've said it many times. I sound like a broken record, but every time we use the pharma money to do certain activities, our hands are slapped to say that we're in conflict of interest and that we're speaking for them. But we have no choice. So there's no mechanism in Canada to do anything elsewise. And how do we don't have a march for rare diseases, and we don't want to fundraise on top of our small groups. We want our small groups to get out there and get the money from their supporters. So I think that's I've never been more hopeful. Like, I've never felt this kind of momentum ever. And, I look at the picture from the rare disease strategy. It seems like years ago when my hair was long and it wasn't gray, but it really, there it is in the middle there. But it really is a message that, this community is empowered and wants to do this. And please give us the tools to do it, and you will not be disappointed. These are passionate people who have incredible lived experience and are incredibly flexible and want to participate. And thank you, Durhan, for letting me say this. I'm very emotional about the whole thing. I look at all these people that are brought together. Some of them I've been, met 12 years ago, and we're all still here and we're all still working, but we've got an incredible momentum now, and I'm really happy to see Michelle in this role, because I've worked with Michelle many times, and I have a lot of faith that she's gonna work with us to achieve what it is that we actually need. So thank you.
Thank you so much. And I think you remind us also, and not to put Michelle too much on the spot, is that government bureaucracies are also made up of people, and it's the right people in the right place that can help move this. So many thanks to everybody. We won't belabor it. Bill, as always, huge kudos to you for the leadership. Look out for the invitation. We will have 23rd and 24th will be 2 days of 3-hour webinars in which we're going to do some case studies. And hopefully the format that we're proposing is that we'll put a case study on the table, invite a panel to really look at what went wrong, what is not working, what did work, and what do we need to do better. And then in June, that second week of June, we hopefully will all be in Ottawa, and if we can keep the trucks out of downtown Ottawa, we will show up and hopefully be able to have this in-person meeting that we have been missing for so long. So thanks to everybody, and happy Rare Disease Day.